abortion reporting, and I think it's a question mark. There we go. So I'm going to start with talking about just some of the background on what we call abortion underreporting. That is, in surveys, people not fully reporting the number of abortions they've had compared to external counts. And then I'm going to walk you through a study that we've just recently finished that is an experimental test of new ways to ask about abortion in a survey. And then finally, I'm going to go rogue. Basically no notes. I'm just going to tell you some of the things I've been thinking about in the last month or so on what are the challenges and pathways in measurement as we go forward post-DOBBS. So throughout this is a very US-centric talk, and it's framed around the problems that we're having in the US. And if that just doesn't make sense to people, let me know and I'll give you more background. I wasn't sure how much you knew about the craziness that's going on here and the environment that we're working in. So this work that I'm presenting today comes from a grant from the National Institute of Health that we just completed. This is a list of publications from it. I'm happy to share this later if people want it, but I just really want to give a shout out to the incredible team that I worked with on this, including Rachel Scott, who I know has been involved in some of the FemQuant work, and other folks at Guttmacher. I have to say, of my whole career, this broad project has been the most fun and the most intellectually exciting of anything I've done, and it's just been a great team of people. So let's talk about the background on underreporting. So in the US, we're collecting data in a couple of different ways. So one of them is surveys of individuals, primarily household surveys, asking them, tell me about all your pregnancies and then how many of them ended in abortion. And that's one bucket. But we also have state reporting systems. So each state in the US, their own Department of Health may or may not require abortion providers to provide data on the number of abortions that they provide and information about their patients. This data is known to be incomplete, so incomplete, in fact, that in the past, the federal government, instead of using these state-level reporting systems, have relied on the Guttmacher Institute's survey of abortion providers, which is this next bucket. But Guttmacher is no longer alone in surveying abortion providers. This is really a growing area of research. And then some people are able to also survey abortion patients. So this literally is going into abortion clinics and sitting in the waiting room and getting people on the day of their abortions to fill out surveys. All of these have different limits, of course, and gaps. But I really today am focused, and this whole grant has focused on individual level survey data. And I want to point out, and this will matter at the end, that we started this, I don't know, maybe 7 years ago, thinking about, when we wrote the grant and started thinking about the ideas. And at that time, we were able to say, look, the abortion clinic surveys are able to get incidence measures. We don't need to worry about whether we can measure incidence. What we need is to have measures that in these individual surveys that connect to other life course events, that places abortion within the context of people's sexual and reproductive health and their fertility and life course. And the surveys of abortion providers and even abortion patients really aren't able to do that well. So we want this individual level survey data. In addition, the individual level surveys lets us compare people who got an abortion to those who did not, as opposed to only being able to study people who got through the door of a clinic. And then these gaps in other systems become a real problem. The surveys of clinics really have an emphasis on aggregate data, which make it difficult to do individual level models. And even when they're collecting data directly from the patients, they're measured on the day of the abortion. And we have to think that that creates some reporting issues, and they're very limited in what they're able to collect because there's just so long they can ask patients to spend their time filling out this survey in the waiting room. Whereas our national surveys household surveys have much more time to do this. So we know that there is underreporting of abortion in surveys. So this comes from when these pregnancy histories are collected. And this has been a recognized challenge for a while, certainly not just in the US. We know in settings where abortion is illegal, which up until 3 months ago was not the US, that measuring abortion in these kind of individual surveys is very problematic. But this is even true in legal settings where abortion is stigmatized. So one of the things we did in this project is to look at reporting of abortion across a range of US surveys that are widely used. And these are all household surveys. And in the National Longitudinal Survey of Youth, the Ad Health Survey, and the NSFG, only 30 to 40% of women report their abortions compared to what we know from the external accounts. The NSFG 40% is in the face-to-face interview, so that's where the interviewer is speaking to the respondent. The reporting is higher in a CASI, and it would be nice if we could just say, great, we're done. We don't need the rest of this talk. Look, we're getting nearly 3/4 of abortions in a CASI. Maybe that's enough. But we have a lot of concerns about this CASI measure. In particular, the way the NSFG has been designed in the last few rounds, we think that this 72% actually represents a misunderstanding of the question, and that women are over-reporting abortion, which I know sounds so weird, but the question asked about abortions in the last 5 years, and it seems that women are actually reporting lifetime. And there's a parallel question on births, so we were able to compare the birth question, and it was pretty clear that a lot of these women were reporting not on births in the last 5 years, but lifetime births. So we think that's happening for abortion also. In addition, because of the way the CASI, so do you all know what a CASI is? A CASI is you get a headphone, it's private, you hear the recorded voice asking you the question, you enter it onto a computer, and the idea is that it's more private and it should produce better reporting. But the CASI is very limited in questions, and it doesn't collect many of the covariates you would want around those abortions. So for analysis, people really rely on the face-to-face interviews, which are severely underreporting. We also were able to look at reporting across US states. So when we looked at the level of abortion stigma and support across states, we found very little variation in the completeness of reporting. So just look at the first category there, which is where we looked at abortion laws, and we divided states into those where the laws are considered hostile, supportive, or middle ground. Regardless of which category of laws these states were in, abortion reporting is still only around 40%. And that is true when we looked at other measures that we thought might be related to abortion stigma, including some public opinion questions around abortion and religiosity in these states also. So one way to think about this is that in the US, the floor for abortion stigma is so high that no matter where you live, you're still not willing to report in a survey. So you can live in New York or California, which are states with great abortion access and theoretic and laws that are supportive of abortion, but the stigma that still undergirds our society around this is so great that abortion reporting is still highly incomplete. So all of this gives what I call a data quality headache. So in our quant work, we found that abortion was substantially incomplete across multiple national surveys. And I really firmly believe that it's no better in anyone's study of hospital patients, their one state survey that they did. These problems are going to repeat again and again. But what's really important is that they're not just incomplete, they're differentially incomplete. And we found that there were certain characteristics that were associated with worse reporting, but more importantly, there's things that aren't measured that are probably associated with worse reporting that we can't identify. But this being differentially incomplete means that the data is biased. And most people, I think, have been skipping over that fact. So what's been very common is to say, oh, well, sure, it's underreported, but we'll be conservative. So our conservative approach is to say we're capturing some, but not all of the abortions. Well, that may be true for a count, but as soon as you want to start looking at relationships between abortion and anything else, you're going to have bias because of this differential underreporting. And we looked over waves of data, and we found that there were no improvements over time. And if anything, abortion underreporting has gotten worse. So this problem, I think, is growing. So we wanted to think about not just what abortions are missing, but what does this mean for studying pregnancies? And we found that overall, almost about 11% of pregnancies are missing from the National Survey of Family Growth because of abortion underreporting. And you can see that these numbers are even higher among some groups, and some subgroups, in particular, unmarried women and non-Hispanic Black women are almost 20% of their pregnancies are missing, which are exactly the groups that our public policies are often trying to change their behavior or address their needs, and yet we're missing 18% of their pregnancies. So this data, because of abortion underreporting, this data is very inadequate. So incomplete abortion reporting has broad implications for demographic and public health research. It certainly limits research on abortion and any whether that's trends, levels, differentials, or abortion safety, but it also impacts any research that requires data on all pregnancies, things that demographers study all the time, like unintended pregnancy and contraceptive failure rates, interpregnancy intervals. Abortion, and I think this is really important because it means that abortion underreporting isn't just an issue for the small set of scholars who study abortion as an outcome, but anyone studying pregnancies more generally. And I don't think we've been very effective in communicating the limits of this data to this broader group of researchers. So in fact, the National Survey of Family Growth for years has placed a warning in its users manual that says basically don't use our abortion data. You can use it for methodological studies such as the ones we've been doing, but not to be used for substantive research focused on the determinants and consequences of abortion. This warning is not well followed. It's really often ignored. When we submitted one of our papers to demography and the editor wrote back and said, doesn't everyone know abortion is underreported in this survey? We did a quick analysis and found about 2,000 citations in the recent literature, which were referring to papers that had used the abortion items in these surveys for their research. So the impact of this underreported and biased measures is very wide across the field. So driven by this, in this project, we embarked on a body of work to improve abortion reporting in surveys. Across the years of this project, we conducted a substantial body of mixed method work to help develop new measurement approaches. Our efforts throughout the project, our efforts were informed by theory-driven work on abortion stigma, on methodological research on survey design, and we also had ongoing expert advisory input. All of this work, which included secondary data analysis, cognitive interviews, and a developmental survey along the way, informed the design of a national survey to experimentally test different question approaches, which I'll focus on today. And our experiment was pre-registered. It was the first time I've done that, and it was really a helpful and interesting experience. But I show you all of these steps to document basically that we just didn't go out for drinks one night and chat about making a better question. I mean, we did that, of course, but we also spent an extensive amount of time in this rigorous mixed method process, considering different approaches to test in the experimental survey. So all of this drew from theories around abortion stigma, which is theorized to influence individuals' willingness to report their abortion experiences in surveys. Now, most likely, respondents don't report sensitive behavior because it's socially stigmatized. So they face social desirability problems. But it may also be that the question is considered just too intrusive. It's just none of your business, and I'm not going to tell you, which we know often happens with income, for example, and income has the most missingness on surveys. Additionally, though, our qualitative research suggests that some abortion misreporting in our surveys could be due to comprehension issues if respondents are unclear about what experiences to report as an abortion. And certainly in the US right now, we're seeing literally every day in the news cycle ongoing stories about a lack of a common agreement about what is an abortion versus a miscarriage. And if the doctors don't agree, why would we expect that respondents all have a shared understanding of this? And you may have seen Joe Strong present on some of the qual work that we've done around this, on what meaning people bring to these questions. But here I'm going to focus on our experiment. So we first focused on testing different approaches to question placement. So generally, researchers agreed that sensitive items should be asked later in a survey, believing that respondents may have developed more trust or commitment to the process as the interview goes on. Also, respondents may be concerned that answering yes to a sensitive question will result in even more intrusive follow-up questions, or that it just extends the interview length. In the NSFG, if you say yes to a pregnancy, there's at least 20 follow-up questions that you're asked. So after you reported your first pregnancy, do you go on to report a second pregnancy, or you don't bother because it's taking too long, and why do you want to answer all these questions? So because of these concerns, we tested if placing abortion measures at the very end of the survey could improve reporting. So the introduction to these abortion questions then actually said, these last couple of questions are the final questions in the survey. Thank you for your participation. And this was meant to signal that there'd be no further question items, regardless of their response. And we contrast this placement at the very end with abortion placement earlier in the survey. But most of what we tested were changes to question wording. So as the control approach, we adopted the current NSFG ACASI item to ask about lifetime abortion experience. So we had to change it a little bit because, as I had mentioned, the current ACASI is about 5 years window, but we wanted lifetime. But in the cognitive interviews, we learned that many women found the current wording of the NSFG introduction problematic. For example, they particularly didn't like the use of the word babies when thinking about an abortion, which is what I've highlighted here in the yellow. And then you can see they're asked to report how many pregnancies ended in a live birth, how many pregnancies ended in miscarriage, and then in the blue, how many pregnancies ended in abortion. So that's our control. If we did it just the way the NSFG did it, what would we get? And then we compare that to some new question wordings. So we tested a new introduction to the abortion items focused on how sharing their abortion experiences in a survey could help improve health services for other women. And we hypothesized that this introduction could improve reporting by increasing motivation to respond accurately. And we also tested changing the order of the pregnancy outcomes, asking respondents about abortion before asking about miscarriage. And here we hypothesized that this new question order might reduce respondents' likelihood of intentionally or inadvertently misreporting a pregnancy as ending in miscarriage instead of abortion if they thought perhaps that miscarriage was less stigmatized. Our third approach here was to reduce the level of detail of the questions. So in the control, respondents are asked the number of abortions, and then you can say 0 or report the number. Instead, we tested first asking a yes/no question, and then asking the follow-up only if they said yes. Our formative research found that respondents feared being judged for having multiple abortions and that asking numbers might be too intrusive. So we thought the yes/no might be more helpful here. We also tested, so in the NSFG control, respondents didn't like that abortion was asked in the context of their other pregnancies. So instead, we tested asking respondents about abortion in the context of their receipt of other sexual and reproductive health services, like a pap smear or a mammogram. And finally, We tested if we could desensitize abortion reporting by first asking about a range of abortion-related experiences, including friends and family members' abortions, before asking respondents to report their own experiences. And we made up this term graduated sensitivity so that the questions got increasingly sensitive as you moved through them. So we tested these new approaches as part of what we refer to as the 2021 Guttmacher Survey of Sexual and Reproductive Health Experiences. This was an online survey using a probability-based panel and an additional non-probability opt-in panel. And we needed both of those to be able to get a large enough sample size to test all of these different approaches. In all, we had more than 6,000 respondents, all assigned female at birth, ages 18 to 49. And NORC at the University of Chicago managed the survey recruitment and fielding. So this is where the experiment happens. Overall, the survey focused on contraceptive behaviors, and we were able to get double value out of the survey. So we had NIH say, we're going to pay you to field a survey to test abortion questions, but you can't just test an abortion question. You need a context around it. And we felt strongly that the context needed to be other SRH measures. You didn't want to do a survey on your employment and then drop in an abortion question. So we designed a whole survey on contraceptive behaviors, particularly related to the pandemic. And then within this, we embedded this randomized experiment. So we randomized respondents to different treatments using what's called a fully crossed factorial design. The question placement approach had 2 levels. So that's the middle of the survey or the very end of the survey. So that means there's about 3,000 respondents in each of those arms. And the question wording had 6 levels, including the control condition, with at least 1,000 respondents in each arm. And in each factor, the primary outcome is if the respondent reported ever having an abortion in their lifetime. And from this, we estimated the average treatment effect using a logistic model. This corresponds to the marginal risk difference between arms. So roughly, it's the difference in the predicted probability of respondents reporting an abortion for each level. We identify any arm that resulted in higher reporting levels than the control condition as the more successful survey strategy. So in this case, we think more reporting is better, and that's how we approach this. So let's look at some of the results. So in the control condition, 17% of respondents reported having had a lifetime abortion. So against this control, we compare the other question wordings. And none of these resulted in significant different proportions than the design condition. That's 6 years of my life, folks. And if you want to see another way to look at these null results, here we graph the average treatment effect and the associated 95% confidence interval. None of the effects were statistically distinguishable from 0, so they don't differ from the control condition. Watch the tears roll down my face right now. And the results of the question placement experiment are no better, with 16% of respondents reporting a lifetime abortion, whether the question was asked last in the survey or an earlier placement. One additional finding was interesting, though. Continuing along, no significant differences, but in this case, there were no significant differences in abortion reporting between the probability and the non-probability sample, which I think was reassuring, given concerns about potential bias and who might have been in that non-probability sample. And then finally, to benchmark these measures, we compared our estimates to 2 NSFG reports. And in this case, we did apply sampling weights. So overall, 16% of the GSRHE sample reported a lifetime abortion. This is slightly higher than the 13% in the face-to-face portion of the most recent NSFG collected in 2015 to 19. But the GSRE was conducted online without an interviewer, so the ACASI might actually be the more relevant comparison. And we found that 20% of NSFG respondents reported a lifetime abortion in the 2002 NSFG ACASI, and that's the last year that the ACASI asked a lifetime measure. So it's hard to know if our reports are higher than the ACASI because we're doing a better, whether the CASI is higher than our reports because the CASI does a better job, or whether the earlier time period overall abortion rates were higher. And we know that's true also. So it's hard to discern here, but they're just not that different. It is reassuring that we also found that for each survey estimate, there were similar demographic differentials. And we really don't know for sure how close any of these estimates are for the true level, because at least in the US, we do not have a gold standard for lifetime abortion. So the best we can say overall is that our experimental design got a similar estimate to the NSFG. So despite this extensive question development process, none of these experimental approaches helped. I do think it provides a proof of concept and a promising path forward for future efforts to test new approaches. The online surveys really offer a less expensive, faster, and easier format than embedding changes in existing national fertility surveys. And I think this is the kind of on-ramp of experiments that need to happen to be able to convince national surveys to change anything. They are changing, for example, that 5-year CASI question back to lifetime based on our estimates that it just wasn't working. So they're responsive, but they're very slow to embed experiments, and it's super costly, whereas these kind of online surveys for us were relatively cheap. I certainly don't think this should be the end of this effort. What we did was, I think, essentially very conservative, right? We just tried little wiggles of changes. And maybe we need more radical approaches, and I'm going to talk about some of them. But first, I want to now do my rogue and think about challenges about what's going to happen post-DOBBS. So let's start with these clinic and patient studies. So I want to stay in my lane. I do not collect this data. And in fact, some of my favorite people in the world do, and I greatly respect their efforts. But the environment in which they are going to be trying to collect abortion data from abortion providers and patients directly is greatly changing. And that is going to create new challenges, and I fear new gaps and biases in the data. Abortion clinics are closing around the US, so you have fewer abortion clinics, which in some ways they should be easier to survey, but on the other hand, they are overwhelmed. That is what we are hearing from providers in states where abortion is still legal, that these surge states have greatly increased demand and is responding to researchers really how they want to spend their time, or ethically how we should be asking them to spend their time. There's also a growing diversity of providers, particularly around telehealth provision of abortion. So how do you bring all of them into your census approach? How do you count everyone, and how do you get data from them? And ones that are for-profit systems, are they going to be as committed to a research endeavor as the nonprofit clinics that we've more typically been able to build relationships with? Some other things that are going to come up is there's going to be later gestation. There's going to be more self-management of abortion, and self-managed abortion is not going to be able to be picked up in these clinic surveys. We need to be concerned about abortion safety. And here, it's not the safety of the procedure, it's the safety for the individual from social, interpersonal, and legal risks. And how does surveying them expose them to greater risk? And this relates to questions around data management and security. I was talking at the beginning of this with some folks who are on that were getting suggestions that we should be storing all our data in Canada, because how do we collect and store the data in a way that doesn't expose providers or patients to risk? But given these challenges, I think we need to be looking anew with renewed vigor at collecting individual level survey data. It may now be the best way to actually get incidence. And again, when we started this, we didn't think incidence measures were the issue, but particularly because clinic counts are going to be missing self-managed abortion, individual level surveys may be the best way to get an incidence count. But it has all of these problems of stigma. So does the DOBBS decision and these new laws heighten the sensitivity and stigma of reporting abortion? Or is it possible that for some people it's decreased it? There's really been a push in the US around shout out your abortion, share your experiences, let's stop stigmatizing this. It's in the news all over. Politicians, activists, people in the public eye are stepping forward to talk about their experiences. So maybe there's less stigma, and I think that's something we'll have to figure out. I don't think we know the right questions in a survey to ask about self-managed abortion. Both, if it was hard to get people to report about abortion when it was legal, are they going to report about it in a setting where it's illegal, or behaviors that they think might be illegal? In all but I think 2 or 3 US states, self-managed abortion is not explicitly illegal, but I don't think most people know or understand that. One of my concerns about measuring self-managed abortion is if you talk to women who show up at clinics and you ask them, depending on how you ask the question, many people, I don't want to say most, many people have tried to do something before they get to the clinic. They did a lot of exercise. They went for a run. They drank something that's a tea that someone suggested, because they'd rather do that and miscarry than show up at the abortion clinic. Well, it wasn't successful, which is why they're at the clinic. But when we're talking about what is a self-managed abortion, I don't think we as researchers have a common understanding of that yet. So how do we write survey questions that make it clear to respondents? And this gets at the question of, do we have a shared understanding of what an abortion is, how that might be shifting with the new national conversations around this, particularly around miscarriage and miscarriage management. I also think we may need to be more creative in thinking that there may not be a one-size-fits-all question, and what works for one group of women may not work for others. I think this may be particularly true in the destigmatizing introduction that we try to write. We tested in our preliminary work 6 different introductions, and some people liked one and some people liked another. It was very varied. So what motivates someone to report or feel comfortable enough to report may not be the same for everyone. I think we need to be worried about who's going to be in these surveys. This is true for any household survey right now. Response rates have been declining, but the extent of distrust in the US about government and public health because of COVID and this great cultural divide that we now have, I'm just not so sure when the interviewer shows up and knocks on the door and says, will you participate in this federal survey? Who's going to say yes, and what that may do to these measures. And I think across, whether we're doing surveys of clinics, surveys of abortion of patients, household level surveys, as researchers, we're really going to need to balance the trade-off between creating data that is timely, creating data that's complete, and what level of detail we want. And it may be hard to achieve the top on all of those simultaneously. Another thing that I'm concerned about is, how do we measure harms? I think they're going to occur differentially and hurt some groups much more than others. States which have banned abortion means that people need to travel. That travel creates a real barrier, particularly to people who are lower income, teens, who I'm very concerned about that I study, immigrants, and other groups. So if we're doing national studies, how do we design them in a way to be able to see what may be heightened impacts on smaller groups? And are our national surveys well designed to do that? I would argue at this point, probably not for most of this. So here are some possible new approaches that I think are much bolder. I can't go into them all in detail, but there's some evidence that increasing incentives actually leads to better reporting. But our IRBs are very concerned that higher incentives may end up being manipulative or coercive. So we have boundaries on that need to be considered. I always thought the next grant I wrote would be about improving the training of interviewers, these middle-aged white ladies, essentially, usually, who show up at your door to do the survey, and to do the kind of values clarification training that we know is happening in other settings. But I firmly believe that the end of interviewers is coming. I think online surveys is the future. And I'm not sure that putting time into the interviewer piece is going to have long-term payoff. My colleagues who use indirect methods in settings where abortion is illegal, I think have a lot to share with us on thinking about what to do in the US. And we have fielded some new experiments using amped up versions of the list experiment and NSUM and some other things. I am not optimistic, but I think we at least need to disprove their value. And so that we can put that conversation aside and move on if they don't work. Maybe statistical modeling. I think we need to lean into qualitative work to fill in gaps that our big surveys can't do. And yet at the same time, I want more data and I want bigger data. And what I really want is longitudinal data because I think the cross-sectional design doesn't really answer many of the questions we're going to want to answer, which was what are the long-term consequences of being denied an abortion? I mean, we have the Turnaway study, which is fabulous, but it's a very distinct sample and study design where I think we want to know these things more broadly. As a demographer, my philosophy really is that counting matters. This is a quote from Gary Gates, who has been a leading SOGI researcher in the US and really led the work on getting SOGI identification in our US Census. And his quote, "Groups often don't count until they're counted," just resonates with me greatly. And I think people's abortions should be counted. But having data and having counts doesn't mean that it's going to be used correctly. This is a graphic from the New York Times that came out just a couple of weeks ago, right before our midterm election. The New York Times incorrectly took data from 2 different studies, smushed them together on their own, and said, aha, there was enough self-managed abortion to offset most of the drop in legal abortions. But they misunderstood the SMA data. And this turned out to be very misleading. So we need to be careful on how all of this data is being used. And that really brings me to the research ethics here. I think we have a balancing act that is going to be challenging. And as I talk to my colleagues in the field, I know I'm finding that people are placing different priorities on different pieces of these research ethics and needs. I think there's a shared belief that that first we must do no harm, and we must make sure that our data collection and our research does not harm the people we think we're trying to help. Responding to these kinds of studies is going to pose a legal risk for respondents, whether they're the people getting abortions or whether they're providers. But there also may be political risk, and the data may embolden bad faith actors. And then we have this problem of misguided interpretation. One of the newspaper stories that came out a couple of weeks ago, the headline was "State Abortion Bans Easy to Evade." Well, it's not easy for the person who had to drive 9 hours, take 3 days off from work, had their abortion later at a later gestation that cost more money, had to find childcare, et cetera, and had a system of grassroots volunteers and dollars from philanthropists that made some of this possible. None of that has been easy. So how does our data get used? There's also a concern that when we point to certain groups as needing abortion or facing challenges, that this can increase stigma, particularly when it's women of color, for example. And my colleague Liza Fuentes said to me recently, and it really struck me, that we don't need more research to know how to provide a safe abortion. We know that. So why are we doing this research? And I think it's to help change policy, but is anyone listening? And I don't, that's been the question for much of my career. So as I wind down, so can we overcome barriers to improve abortion reporting? Well, I hope so, but I do not think it's easy. And I wish I could come here with the if you just ask this question and this question wording and put it at this place in your survey, reporting is going to be great. That is not what we found. But we do need to move forward and keep doing this. So as I wind down here, I just want to note that the root of underreporting is abortion stigma, And as much as I know we all care about accurate measurement, even more important is the impact of the stigma on the people who need, want, and have had abortions. So the best thing we can do is to continue to work to eliminate abortion stigma, and that would improve our measurement, but mostly would improve people's lives. So thank you.
Thank you so much. I'm just going to stop